Seizures, it could be because, of course, of the fact that there's problem with oxygenation of the brain, loss of consciousness, and hopefully the patient could wake up. Okay? So here, anaphylaxis area obstruction occurs in allergic edema. We know that one in vasodilation, resulting in hypotension, perfusion, hypoperfusion of the organs. Severe bronchospasm may occur. The cardiac output falls. In the heart cannot pump enough blood oxygen to the tissues. The brain is sensitive to alteration, perfusion, and the oxygen content resulting in your confusion and loss of consciousness. Okay? So that's one thing. And hopefully, we could revive. Remember, if the brain doesn't receive any oxygen within 4 to 6 minutes, what will occur? Irreversible brain damage. Okay? We're going to stop. And we speak of irreversible, meaning to say it cannot be corrected anymore. Whatever damage we're going to incur to the brain cannot be reversed. Okay? So treatment must start immediately. First one, open the airways. Airway is the first one that you can do. Okay? This may require endotracheal, meaning to say we have to, of course, to put some airway, or we have, of course, to trach the patient. Okay? Or E-tube, endotracheal. Administer medication. Okay? But again, most often, the first one is that here's that. Okay? I would like, of course, to start with here. Remove the patient from the substance first. Because again, even if you try to open the airway, it's useless if still the patient is continuously exposed to the source of allergy. That's why the most common one that will cause a massive effect will be the one that's given IV. Okay? Especially your blood transfusion. That is why in blood transfusion, when we give it, we are monitoring the patient on the first 15 minutes. Any reaction that will manifest at one, and what are those manifestations? Okay? Itchiness. Okay? The most common one that you're going to see is that, oh, I have stomach upset. It means to say that we have some problems already. Or any discomfort that the client will feel. Itchiness in the injection site, okay, or in the entrance site. Probably one of the most common one, SOB. If you are giving blood transfusion and suddenly the patient, of course, starts to complain, oh, I have difficulty in breathing. Then watch out. The next thing, of course, to play safe, stop right away your infusion. Because again, why? The general rule of anaphylaxis or allergy, stop the substance or remove the patient from the substance. If it's blood, then you block, of course, the substance. And then you go right away, open airway if you have the problems of the airway. Okay? And then administer. First drug to be administered will be epinephrine. Okay? And the fastest route for epinephrine is IV. Okay? But if you have EpiPen, usually it will be given subcutaneous. Okay? So aminophylline is another one that is, of course, your bronchodilator. Aminophylline is theophylline is the only bronchodilator that could be given. That's the last one that we gave, of course, is the patient has status asthmaticus. Okay? Major, of course, your bronchodilator. Antihistamines and, of course, your corticosteroids. And usually, these are, of course, the best way, of course, to give. Okay? Epinephrine followed by, again, epinephrine is the number one, followed by bronchodilator. It could be terbutaline, but here, because again, emergency situation, aminophylline. The last line of bronchodilators, and the one that could be given IV. Okay? Your bronchodilators are albuterol or inhalation. Did you see, of course, that the albuterol is given IV? No. But this one, it could be given because, again, we want a massive effect, especially in the lungs, especially in the airways. Okay? And followed by your antihistamines. You can give your chlorpheniramine, your antihistamine, you could get PO or any form of route, or it can be topical, okay? And your corticosteroids, in order, of course, to suppress the inflammatory process. Okay? Support the circulation. Right away, do not remove your line. Maintain the line, and right away, if you have blood transfusion, that line should be used for NSS right away. Okay, to keep, of course, KVO. What does KVO means?
Keep veins open.
Are you sure?
Yes.
Not keep vagina open? Because again, before, during our school, they keep vagina open, okay? This is only for a joke, but let's keep vein open. Because why? You need it for access. You need it for
Why are you
access.
blushing on?
And usually, of course, it will be around 10. What is the KVO rate? What is the KVO rate?
It's not a nice joke.
How many drops? So, you know KVO, but again, you don't know to calibrate your KVO. If the doctor will keep KVO to your NSS, how would you regulate that one?
How much one?
1 drop per minute? Then you can compute, of course, 1 liter to run for 8 hours. Macro drops. Drop factor, 15 drops per ml. Okay? But what is your KVO? Okay? So let's look for that one. And of course, with that one, hopefully we could reverse. Again, the only purpose for that one is that to make sure that the patient is respiratory stable, and pulmonary stable, and another one is the vascular stable. So no hypotension. Okay? So those are, of course, your anaphylaxis. That's how we reverse an allergic response. Okay? Immune disorders, what are this one? First one, what are your immune disorders? Infection. Infection is your number one, isn't it? In infection, what happened in infection? The invading microorganisms is stronger than our immune system. Not only the immune system antibodies, but again, it can even defeat your neutrophils. Okay? So another one for the one that is what anybody who has an infection has a problem with the immune system. Okay? Because the immune system cannot defend the human body. Okay? Another one is immune suppression. The immune system function is depressed. Perhaps it could be, of course, due to injury, shock, radiation drugs, immunosuppression, and maybe congenital agammaglobulinemia. Meaning to say, this is, of course, the state wherein the patient does not produce globulins, gamma globulins. And when we speak of gamma globulins, IgG, that's the basic fundamental structure of all your antibodies. So just imagine if you don't have any globulins, especially gamma globulins, so how could the patient has plasma cells, but the plasma cells doesn't have any scaffold or form or basis to form your antibodies. Therefore, this patient cannot form antibodies. Okay? If you don't have any antibodies that is inside of you, eventually anything, of course, could happen right now. Yeah? Another one is overproduction of gamma globulins in malignant blood disease or chronic infection may be indicated, but I don't see any much, of course, of anybody who is producing a lot of gamma globulins. Okay? But usually it is a very, very rare case. But commonly, the most common one is your immunosuppression. So again, infection. Is allergy an immune disorder? Definitely. Severe immune response to invading antigen. Your anaphylaxis. So your antigen could be anything that your body is responsive to. It could be, of course, if it is can cause allergy, we call them allergen. Okay, so the only difference between antigen and allergen is that an allergen only causes allergic response or anaphylaxis, but an antigen could cause both anaphylaxis and infectious response. Okay? So another one is rejection. Sometimes we have our body parts is broken or it's destroyed or damaged along the way, so we need it to be replaced. So we call it one. We cannot just go to Home Depot or Lowe's or Menards to buy some parts of our body and put it in. Okay? We need some other body parts in order to do with us. What we call it one as your transplantation. And in your transplantation, one of the most challenges is that how would you contain your immune system, especially your T lymphocytes, that knows inside out if it is self or non-self. Okay? If that foreign tissue, the transplanted organ, definitely will be labeled by the T lymphocytes to be non-self. Okay? It will be destroyed. That's the mandate of the immune system. Therefore, in order for that transplanted organ to be maintained and can function in the patient's, in the host's body, we have to suppress the effect of the immune system. So again, your rejection response of beneficial foreign substance placed in the body is rejected, such as the most common one is your graft versus host disease after organs or tissue transplant. Okay, that is why, as I have said, if you have a dead kidney, grafting a new kidney or transplanting a new kidney is not a cure. It is only one form of treatment. Okay, always remember, in a disease when there is graft, okay, except the graft could be autologous or allogenic. It is of the patient's own tissues. Then we don't have any problems. That is why, if as possible, the technique in allograft or your allogenic grafting, or it will be emphasized if it could be possible, so that there is no form of rejection. Okay? So if you receive your, like for example, cultured epithelium of the grafts, if it will be grafted in the area, of course, wherein you don't have any epithelium or you don't have any dermis. Okay? So it is okay. It will gonna regrow. It is your own body, therefore it will be not rejected. But what if it is, of course, the skin of another person? Okay? If that is a skin graft, it should be maintained with your immunosuppression or your rejection medication. Okay? So anybody who received a transplanted heart, liver, kidney, or any body part, okay, should be maintained in your anti-rejection medication. Because why? In any time, if you don't suppress the rejection power of your lymphocytes, definitely those organs will be wasted. Okay? Okay. So disorders and autoimmunity is another one. So the body does not recognize or tolerate the self. Okay? So sometimes at home, you are one family, but sometimes you quarrel with each other, isn't it? Even your husband and wife, sometimes during the process, you love each other, but you are honored with the other one sometimes. And up to the point that it's a heated debate. Okay? Hopefully it did not turn physical. And sometimes you scream at each other. Okay? So sometimes you don't want to talk to each other. Up to the point, of course, that you hate. And later on, you cannot also contain that kind of relationship. So you regain the good relationship again. What do you call that one? You reconcile.
Counseling.
That's why some women here, of course, are pregnant. Okay? So during the reconciliation process, it is when there's a loved one.
They're all
Anybody's
looking at
pregnant
me.
here? That's why sometimes a lot, of course, of those relationships, love-hate relationship, we're going to produce, of course, good ones. Okay? It is very productive
After the
relationship.
fight.
But it happens. What if it is, of course, your own body? One mandate, one system, one type of cell. Okay? Or one genome. So sometimes it can tolerate its own, the healthy tissue inhibit normal function, it results in damage of the body tissue by the immune system. So just imagine your lymphocytes, your not cytotoxic T cells. Okay? Cytotoxic T cells or your killer T cells, they are killing, of course, your own. Even if it is still a good guys, it's still very part of ours. Okay? So that's one, of course, of the worst common form. So sometimes during the time, believe it or not, well, how do we treat autoimmune antibodies? Autoimmune disorders.
Cancer medications.
Cancer, yes, we're going to suppress, of course, the inflammatory response. It could be. Huh? NSAIDs? Okay. But did we fix it? We just put, of course, the human body into at risk, of course, of the suppressed inflammatory process. Did we create a correct fix? Those are just, we call them palliative treatment. Do you know what is palliative treatment? Just to contain the symptom, not the problem. The purpose for that one is to alleviate the pain and suffering of the patient. That's why if you're in palliative care, there's no such thing as aggressive care. Okay? Just to keep the client comfortable. Okay? So now the question will be, could we correct this one? Actually, there's no form of correction in autoimmune disorders. The patient has to learn how to live with it. Or another one is that in the event, there's a period, of course, that the antibody might be so strong during the time that it creates a lot of damage and the patient will be so sick. We call it the period of exacerbation. And sometimes the activity of the antibodies of the immune system is not too bad. So again, the patient feels better. We call it remission. Okay? Remission and exacerbation. Those are the areas, of course, especially manifested in your autoimmune disorders. Okay? So what are the factors of autoimmune disorders? It could be genetic predisposition and influence of certain antigens and rejection of the person's own tissue. Okay? One of the most common examples for this one, especially organ specific, we call that one is your diabetes type 1. Okay? At birth, the patient or the baby has some antibodies. Of course, genetically, there, of course, might be a problem that the baby's own antibodies destroy his own beta cells. Okay? Thus, the pancreas does not produce any form of insulin at all. Okay? That's why diabetes type 1 is one, of course, of the most common example of your autoimmune disorders. Therefore, if some, of course, of our body parts is not functional, it could be that it's autoimmune in origin. That's why the concept of autoimmune always surfaces. Because it might be, of course, a great risk because our body is producing antibody that kill our own cell. And again, that's example for that will be your DM type 1. Okay? So interaction with physical, chemical, and biological agents trigger abnormal immune response. It could be a form of radioactivity or any form that triggers, of course, abnormal or abnormal immune response. Another one is our abnormalities in immune cells that lead to an inappropriate immune response. It could be a deficiency in vitamin D. Okay? So examples of autoimmune diseases include diabetes mellitus type 1, rheumatoid arthritis. In rheumatoid arthritis, our body is reacting, of course, with a very high rheumatoid factor. Thus, in this time, in rheumatoid arthritis, patients' joints, okay, is being attacked by antibodies. Okay? And usually it goes away, but sometimes it creates damage to the patients. Okay? Multiple sclerosis. What is multiple sclerosis again? Multiple sclerosis. These are the area of damage of patches created by autoimmune antibodies. Okay? You know where? In the brain. Okay? Multiple sclerosed areas causing, of course, your cognitive decline. We're going to talk about that one if we reach, of course, your neuro. Okay? That's one. Another one is your hemolytic anemia, wherein, of course, that your body is trying to destroy your own RBC. Because, again, the body's antibody, our body is producing antibodies that kill our own RBC. In the event, then, of course, there's only few RBCs causing, of course, your hemolytic anemia. Okay? Myasthenia gravis. What is myasthenia gravis? MG. Myasthenia gravis is also known as your ascending paralysis. Okay, we're going to talk about that one, but again, here is a problem, of course, of your nervous tissue. Okay? Wherein there is, of course, a problem, and then a distraction until such time that the patient will gonna be suffering massive form of paralysis. Okay? In the worst form, the myasthenia gravis, if it will involve the diaphragm. If it involves the diaphragm, patient cannot breathe on its own. Okay? Systemic lupus erythematosus. Any systemic lupus erythematosus, again, in the scale, we could do, of course, your butterfly rash in the face, but it's not only it. It attacks your joints. It destroys the joints in systemic lupus erythematosus. It also destroys your lungs, okay, or all the parts of the body. And again, there is no treatment for that. Only the one your discoid lupus erythematosus. The only great difference between SLE and the discoid type is that the discoid type is only in the skin. Clear? Discoid lupus erythematosus is displacement, of course, of discs. Okay, just like who's that again? The husband of Heidi Klum Seal. Okay, that is discoid. But the other one, of course, with a systemic lupus erythematosus, it has butterfly rash in the face. Discoid does not involve any part of the body except skin. But in systemic, it involves the lungs, it involves the joints. Okay? It could also hamper the function of the heart. That's why this systemic lupus erythematosus is one, of course, of the most common, of course, problems, especially in the autoimmune antibody. Your myasthenia gravis, okay, could be, these are the disorders that during this acute exacerbation, except your DM, because once the DM type 1, there's no cure for that one. Okay? Although, we might be having pancreatic transplant, but again, it does not correct the problem itself. Okay? Because again, in transplant, it is just part, of course, of possible, of course, growth of a new tissues or B cells that we're going to produce your insulin, but it is not the complete fix. Okay? That's why in your DM type 1, the only way to treat it is no other than insulin. So any deficiency of a substance, the only treatment is replacement. So we have to replace with your insulin. Okay? So types, of course, of this form of autoimmune will be your organ specific, especially your transplants, or the other one, for the one is that your DM, which DM type 1, which affects, of course, your kidneys. Okay, rheumatoid arthritis, your joints, okay? But in SLE, it's multisystemic, okay? In your myasthenia gravis, it's multisystemic. Okay, multiple sclerosis, it could be in the brain, but it could involve, of course, systemic manifestation. So personal risk of familial tendencies, so sometimes it goes in the blood. It could be genetic. Because some parents who develop autoimmune disorders, okay, usually children or offspring are noted to develop one. Okay? Multiple autoimmune disorders are known to occur in the same client. Sad to say, DM type 1 in the patient has the same is true systemic lupus erythematosus. Okay? Or the patient has rheumatoid arthritis. In the future, the patient might develop multiple sclerosis. Okay? So that's one. Women are more likely to develop autoimmune disorders, 10:1. Sorry, women. Okay? So 10:1, so autoimmune antibodies. That's why in SLE form, it is very notorious to affect the women. Okay? Thymic hormones, sex hormones, okay? And corticosteroids play a significant role in this ratio. And the old sex hormones, because of course that, it is of course better to have testosterone because testosterone prevent the activity of the immune system rather than estrogen. Okay? So in that case, of course, it shows why women are at risk to develop a lot of autoimmune disorders. Yeah? Another one, again, specific, organ specific, is your rejection of transplanted organs. A transplanted organ is a foreign substance, and the recipient immune system will reject this foreign substance unless specific measures are taken to prevent it. And the only way to prevent is suppress the immune response. Immunosuppression. That's why immunosuppression is a bad thing. Because why? What is the greatest risk in immunosuppression? What is the greatest risk in immunosuppression? Infection. Okay? So because again, usually why we suppress the immune response, therefore, if there's infection, your immune system does not react rapidly to defeat this infection. And again, it put, of course, your defenses down. Because of that one, definitely it will gonna possibly destroy the patient. Okay? Another one is that in tissue typing, to obtain the most genetically compatible, although we do that one exactly the same way as blood typing, okay? In tissue typing in your transplants. Sign of rejection will be fever and chills, hypertension and hypotension. Hypertension first, and then later on, hypotension. Edema, signs of organ involvement, especially if it is local. To suppress in rejection, immunosuppressive drugs are given for life. And again, I would like to remind you, immunosuppressive drugs are given for life. So if you have been received kidney transplant, okay? I saw one of my cases, of course, in my patient. She's 23 years old, okay? End-stage renal failure. She's been through dialysis. And she's so uncompliant. And you know what? I want, of course, to know that she's already status post-transplant 2 times. All of those 2 times failed. In the UNOS, the organ network for organ sharing, UNOS, United Network for Organ Sharing, we're going to reject, of course, your application for a 3rd one, unless otherwise they were going to look, of course, for another kidneys. Okay? So usually, because it means to say that first one, it failed, it may be caused. It may be substantiated that what caused it, and again, you will be given another chance. And if your second chance has failed, then usually, barely you will get a 3rd chance. Okay? So the worst form, of course, of organ transplant that I've seen, of course, will be the man, of course, has end-stage renal failure. The wife loves him dearly. Okay? And there's no organ, and they are waitlisted, of course, for organ donation in UNOS. So the wife decided to give her kidney to the husband. Okay? So the wife has only 1 kidney, the husband has 1 kidney, but they were not able to live happily ever after. Because after 15 years, and then it's very run smoothly. 15 years, the kidney transplant went very fine. And then one day, the husband got sick. Okay? And it starts, of course, to start organ collapse. A lot, of course, of the system was involved. And we tried to find out what's the problem with the patient. Okay? And the patient developed cancer in the liver. And it has metastasized to the lungs. Because why? One of your risks, if you are immunosuppressed, will be cancer development. Okay? So sad story. The wife is crying because, again, he cannot tolerate his husband go. They're still in their 60s at the time. So the husband, because of course, more than organ failure, because of the cancer, went into coma. And then in that case, of course, the husband went out of coma, but has to undergo dialysis back again. Because the kidney has been, again, has collapsed, secondary, of course, to infection cancer. Okay? So sad story in my line of work, sometimes I saw that one, and again I would like to emphasize only immunosuppression could cause two major, the most immediate one is infection, the second one is cancer development. Okay? Note that one. If you select all that applies, infection will be number one, the second one will be cancer development. Okay. So that's why if you have been transplanted with an organ, don't be so happy because it's very hard to maintain. Okay? But at least your function has been extended. Okay. So if the immunosuppressed drugs are not effective, the organs will be rejected. Okay. The only thing for that one is that right now we don't have any. What kind of part of our body could we transplant now? We have the first part of the human body that was transplanted is
the eye.
the eyes.
Kidney.
Part of the eyes, not the eyes.
The cornea.
The cornea. Okay? Why? Because sometimes the cornea doesn't have any blood vessels. That's why the rejection is very low. Although they could be maintained in the rejection medication. Okay? Followed by other body organs, just like your first one will be your kidney, another one will be your heart, okay? Lung could be, liver transplant could be, pancreas could be, penis could be. Okay? Have you heard of course of penile transplant? So the problem to that, if you have penis transplant is that if you're Asians, okay, the doctor will gonna ask me, what penis, whose penis you want to be, black or white, Italian, Indian, Mexican? So what do you want? So how would you choose? Okay. There's only one I know was that underwent penile transplant. Okay, and it is from cadaver. Okay. But again, remember, they say it's true also, of course, in the tissue typing. You cannot put horse's tissue onto the pen. So again, you cannot transplant from horse to the man. Therefore, only man to man. Okay? Because again, the same tissue is to type. And the only one was, do we do that one here in the States? We do, of course, sex reverse. It's reverse operation. But we don't do sex transplant. We don't do penile transplant. Because, of course, of the ethics. Both, of course, Europe and US does not do that one. But there's an attempt. Have you heard of that? The first attempt of penile transplant was done because, of course, the guy has a serious accident. So he decided, of course, that he could have a penile transplant. Okay? Which country it happened? China. See that? And sad to say, of course, that when the husband, of course, decided to have penile transplant, the following day he decided to take it off. Because I don't know what happened, so again, they reverse, of course, the transplant, they cut it off. Okay? That's the only human, of course, attempt to do penile transplant in this world that has been documented. In the Europe, here in the United States of America, because of ethical issues, we don't do that. Okay? So that's already part, of course, of the organ transplant. Okay. So that's one thing, and again, you have, of course, to be maintained. Okay. Rejection, the transplant organ, and the okay. Another one is your lupus. Lupus is the chronic one. Causes the development of antibodies that fight our own body tissues and cells. Attack skin, attack joints, attack the lungs. Okay? That's why systemic lupus erythematosus could kill you. Okay? So there's a widespread damage to the reproductive tissues, hematologic system, skin, kidneys, heart, and brain. That is for SLE. And do we have treatment for SLE? No. The only thing is that because it's autoimmune, okay, because the antibodies is inside us, the only way is that we are always pushing for remission. So when it's in remission, we don't have much symptoms. Meaning to say the patient could go on in his daily life because, of course, there's no much manifestation of the disorder that will limit his function. Okay? Education on rest, stress management. Sometimes we use, of course, yes, anti-inflammatory agent and corticosteroids. But sometimes the major attempt, of course, for this one is we have to remove the antibody. Okay? So characterized by inflammation of joints, systemic manifestation. This is your rheumatoid arthritis. Joints and systemic manifestation. It could affect, of course, a lot, of course, of your body parts. Okay? Treatment. Induce inflammation, steroid, radiation to suppress body's abnormal antigen antibody response. Therefore, radiation therapy could also be used to target organs that will be producing a lot of antibodies. Okay? And one of the major treatments, especially myasthenia gravis, exacerbation of multiple sclerosis, another one is that, oldest one is that the only way, of course, sometimes to handle, besides, of course, your anti-inflammatory drug and your corticosteroids will be, but again, autoimmune disorders, the mainstay treatment will be anti-inflammatory drugs and your corticosteroids. If it's local and you can point the part of the body, radiation. Okay? And another one that is not in your book, the part, of course, that I will be doing next. Later on, I want, of course, to involve that one because I want to reach that level. I want to know how to do it. Okay? Sometimes in the human body, what causes rejection or what causes the autoimmune disorders? What causes this pathology? What causes the damage? What causes the damage in autoimmune disorders?
All cells.
Be specific. What kind of cells?
Recognizing the factor has a problem.
Nope. What are cytokines are just a product of these cells. But what causes the rejection? The rejection of organs. Another one, of course, is autoimmune disorders. What causes it? What component of the human body? Again, autoimmune antibodies. What is the problem there? What is the pathology in autoimmune disorders?
Destroying the own cell.
Huh?
Destroying the own cell.
What cells are you killing the cells? Be specific. When we speak, of course, of cellular level, are we talking about lymphocytes? Are we talking about the leukocytes? Are we talking about neutrophils? Are we talking epithelial cells? Be specific.
T cells.
I don't think so. You are talking about the rejection performance and not autoimmune disorders.
When the T4 doesn't...
Be specific. What is the pathology in an autoimmune? Example, DM type 1.
beta cells, you say,
What happened to the beta cells?
is destroyed.
By what?
Okay.
Who destroys your beta cells?
Liver? No.
I am talking to the cells because this is the basic core. Yes, you're right, but they want, of course, to know the specifics. So, Ms. B said, our own cell kill our own cells. What cells are we talking about here? Does the liver kill, of course, your pancreas? How? And what is, of course, the mechanism? You are almost right, but I want specific answers. What is the pathology in autoimmune disorders?
The white blood
Is
cells
antibody?
Very good. That's what I want to hear. Antibodies destroy our own cell. And antibodies, again, antibodies. And when we speak of antibodies, we are talking about your IG, immunoglobulin. And when we speak of antibodies, we have your gate, the gate or gate. Okay? And the most potent one will be your
IgG.
Now, I want to ask you, where could you find your IgG?
From your mother. You get from your mother to the child.
Yes, I know plasma cells. I know that one. It
GA.
will be the one produce your antibody. I agree with you, Miss B, but again, which part of your body we could find your IgG? Go back to your book.
In the tissues.
Are you sure we have IgG in the tissues? Take a look again.
The blood.
Again, the answer will be blood. Part, of course, there are some tissue that has some IgM or IgD or IgA in the tears. IgM could be present in the tissue, but primarily your IgG is present in
Mostly in the blood.
the blood. Now, blood could be found in your blood. Could we remove this IgG from the blood? Okay, let us, the second person, but this blood. Blood. What is blood?
Red blood cells.
Huh?
There's plasma cells in there.
Oh, not plasma cells, but again, what is blood? What is the components of blood?
RBC,
It's only part of it,
WBC,
but divided two parts. First one is your
red blood cells.
fluid part,
Oh, fluid.
and the second part will be your solid part. without question, your solid part are your yes. I agree with you. RBC.
Plasma.
No, platelet.
Plasma is plasma solid?
No.
WBC.
This is plasma.
Yeah. WBC.
Okay? RBC, WBC, and platelets.
Platelets.
Separate them together. We have your solid components and your fluid components. And the fluid components of your blood is what we call as your plasma. And here in this plasma, it contains, of course, your IgG, because this is not the solid portion. These are the bigger ones. So your proteins, your electrolytes, where could we find them? Here in your plasma. Okay? And where could we find your albumin? Plasma.
Plasma.
Okay? So why not? Think about it. If IgG is the one that causes autoimmune antibodies, although we cannot remove 100% of it, why not we separate the solid portion in the plasma and remove the plasma of the patient? Could we remove the patient's plasma?
No.
The answer is yes. It is just a process. If you have some certain part of blood, your blood will gonna go. Will go, of course, in a machine that creates a circular motion. We call it one centrifuge.
That
What you said, Regina? What do you mean by that? Did you see this machine that
Yeah.
turns, that we put, of course, the test tube, it turns, and later on we spray the solid portion of the blood, and on the top, of course, the yellowish portion of plasma. You see that? Then centrifuging this one, okay? Okay, we're gonna separate the solid and the fluid, the plasma. If we were gonna remove the plasma, could we? Yes. Could it help the patient with autoimmune disorders? The answer is yes, especially at the point of exacerbation. The only problem is that the patient cannot survive without plasma. Therefore, if you remove the patient's plasma, you have to replace it. Okay? Removal of the own patient's plasma plus putting a new plasma is what we call the process known as your plasmapheresis. And this is done during the exacerbation of autoimmune disorders. This is an advanced form, okay? It was not basically being built, but during the exacerbation of autoimmune disorders, we do plasmapheresis. And yes, next year probably, I know how to do it already. Now, yes, what is your question?
they use under the eyes to get around the
The,
plasma. They put it under the eyes for the take out the
what's the plasma, to remove, of course, the eye bag?
no the dark circles. They got new treatment.
Plasmapheresis?
Yeah.
No.
No, not plasmapheresis. Just a plasma. They take a plasma, separate it, you
Uh-huh.
say, and then the injection.
We call it
They
one-
put the injection
centrifuge
here.
is what we call as your plasma separator.
They call the PRP.
Okay. Yes, that's another modality that we're doing right now.
Yeah.
Because the purpose for an eye bag is only fluids. If you put plasma, you have a lot of albumin there.
Yeah.
So if you inject that one, it will the albumin will gonna suck off the fluid. Still the same principles in fluid electrolytes. Because your albumin is the only protein in your plasma that pulls all the fluids back to the vascular system. If you have eye bag that fills with fluid, it is just edema. You put, of course, plasma there, then the same albumin will be, usually, it will gonna pull, of course, the fluids, whatever the technique for that one. But again, this is the technique or the process that we know right now. Okay? So note, if for example, in the patient who has ITP, idiopathic thrombocytopenic purpura, usually idiopathic thrombocytopenic purpura, meaning to say purpura there's bleeding or there's mark. Idiopathic, meaning to say that we don't know the cause. Thrombocytopenia, the thrombocytes are being dead. Antibody kills them. Okay? So because of that one, the tendency of the patient could bleed. So in that event, sometimes, okay, that's the first plasmapheresis I went to, and of course, in my company, we have division that does plasmapheresis. Okay, and they went, of course, to our staff who does that one, and she explains me the process. Okay? Just imagine in one process, if we remove the plasma of the patient of 3 liters, we have to have, of course, 3 liters of plasma to replace the one. Okay, remove it, while we are replacing. So the process will be, we centrifuge it, remove the patient's plasma, put the new plasma from the blood bank. Okay?
How come there's no, okay, if we do the plasmapheresis and remove the plasma and put a new one in there, for the autoimmune disease, right? Still there's no cure though.
Mhm.
So by doing that, what does it do? I mean, the person is still gonna still have his rheumatoid arthritis and everything though,
Why
right?
that's corrected. Isn't that?
Yeah, it's not, right, it's not corrected, but
Correct.
it's still right.
In the process of plasmapheresis, okay, I would be glad, of course, if we could remove 100% of the plasma. But you could have processed at the same time. This is the process. Therefore, once I remove the plasma, there's still plasma left. It will be dissolved and replace it. But it's not all the time, of course, the plasma of the patient. And remember, one of the basic important rules in the immune system, in antibody formation, antibody has memory cells. Do you think you can remove 100% of that antibody?
So the one-
Even just one, Mr. Jones, that one antibody, one memory cell of the antibody will produce another clones. Okay? That is why we could have cured it. How I wish we could do that separation all at the same time. But if you remove and separate, of course, the entire blood system of the patient, in the first place you're not accessing it. Okay? Even the reservoir of blood. So again, the role there in plasmapheresis is that remove as much plasma as you could for the patient, thus removing most, but not all, of the IgG, thus decreasing the inflammatory response. Clear? That's why we cannot correct autoimmune until point in time. I don't know in the future with that kind of technology if we could, but right now, no. Okay, that's the most common thing, of course. And always remember, in antibody development, one memory cell could clone itself to produce millions of new clones. Okay?
Maybe they can,
Yes?
the new technology can just
Okay.
the
What's
new
that?
No, the new technology probably can replace just memory. So,
I don't know. That's a very, very thing because again, it's organic. It evolves. So I don't know how we could hamper that one. Although right now, even right now, we have your MOABs. Take a look at the technology advancement right now. Your monoclonal antibodies. So usually, this one is that the cancer cell itself, we create a target cell, and we of course produce a cell here. It's a MOABs. What we do is that we fuse them together. Therefore, we train these new antibodies to seek and destroy the paired tissue. And if the paired tissue is a cancer, these MOABs will gonna float in the bloodstream and target all those cancer cells and kill all those cancer cells. Okay? But again, the only thing is that that's microcellular level. Until such time, could we do it 100%? I don't think so. Because again, one cell, especially one antibody, one memory cell, could produce another millions of its copy of itself. Once it is activated. Do you get what I mean? So the only goal for here in plasmapheresis is usually promote remission. Meaning to say that the height of the inflammatory process will be reduced and the symptoms of the patient will be reduced. Like for example, in this patient that we did ITP, that I followed of course with our staff, the patient's platelet is only 10. 10? What's the normal platelet again? 150 to 400,000. In the patient is only 10,000. So the patients could just eventually bleed. If the patients bleed, there's no platelet to seal it off. So any injury, of course, could cause hemorrhage. That's why we have to remove, again, we give platelet. We give plasma to the patient. We give platelets, but again, we have to remove the old patient's plasma and replace it with a new one. Okay? And that is that technique. Any questions? So those are your immune system disorders ranging from infection, your autoimmune antibodies, so you know now the pathology of autoimmune antibodies or your autoimmune disorders. Okay? So in this are of course one. And the next part for this will be your HIV. What do we know about HIV?
it's no cure.
Isn't Ant-Man in the board? Ant-Man? Who's the villain in Ant-Man? Anybody watch Ant-Man? John, did you watch it? Oh gosh. Who's the villain?
Yellow jacket?
Yellow Jacket?
Yeah.
Is he a wasp?
No.
WASP is, no. WASP is, WASP is the girlfriend's mother. I know the one who went into the thingy, the beyond, okay, were able to come back. So what? That's WASP. That's the mother. So a yellow jacket is an insect, isn't it? I think so. Okay. So I'm just asking because I just watched it this morning. But was showing in stars this morning, isn't it? So good thing I was off. I went home instead of home. Okay, HIV. So what do we know about HIV? Are you sure as nurses? Are you aware that? But what the heck is that one? If the patient is HIV positive, why can't we read it even in the chart? Isn't it? Take a look. Now, sit down, take a look at the person beside you in your back. Are you sure they're not HIV positive? Are you afraid that somebody is HIV positive?
I'm not sure. We should do it first.
Take a look for that one. You've been already as PCTs, CNAs. If you're taking care of the patient, of course, in your care, was it revealed to you that this patient has HIV?
No.
Did you know that the patient has HIV? It's documented in the chart.
I think it's confidential.
But the hearsay, and sometimes even as a nurse, in my experience, not all the time you know that the patient is HIV positive.
Is it illegal for the nurse to tell? I mean, it's
Definitely, if those people, of course, are outside
the health thing.
the healthcare team. Okay, but again, if it's within the healthcare team, of course not.
Yeah,
Okay.
because I know so.
So it cannot be revealed because that's a personal issue. The same is true with mental illness. Okay? So, but not all the time we've been okay. Why not, of course, all the people who are going to come into that room, contact precaution, HIV positive on the wall. We don't do that one, isn't it? You don't even know. It is subtle. It is silent. And they usually is just,
Yeah. That's what it
okay? But if it is TB, take a look. Shh. Lock, double door.
Yeah.
Okay? It's not only droplet. It is airborne precaution, complete closure of the rooms. Before you could open the rooms, there is anti-rooms.
Yes, to put your glasses.
Okay? And you have to use N95. The first question will be, what is the size of your N95 respirator? I am regular. Okay? So that's one of the time, because again, you have to use it. Okay? So that's one thing, but again, why HIV? So do we need, of course, to fear people diagnosed with HIV as clinicians, as healthcare workers? And why the heck, for our safety, why is that revealed totally for us, so that we can prevent ourselves, okay? Have you ever wondered that? But if the patient has TB, hold overboard, PTB positive, okay? Suspicion, airborne precaution. Everybody knows, including housekeeping, okay? But if it's HIV positive, we don't bother, of course, or the documentation is not, of course, that big deal, okay? It is only known across the healthcare, even the nurses will not tell you in harsh voice, be careful, HIV positive. Okay? And what is HIV? How do you understand HIV? That's the question for you will be, how do you understand? Do you fear HIV? And as a clinicians, do we fear, of course, HIV?
Yes.
If you got, of course, a needle stick, if you put, of course, a needle stick, of course, to somebody with HIV, and you accidentally stuck yourself,
You mean.
okay? Do you have a chance, of course, good luck for that one? Do you think you're going to get HIV?
It's not if you have
No, you have to be tested.
SV cell, if he's a present SV cell, then he's get a host.
What's that again?
It's SV cell.
What is the cell you're talking about? Be specific. Right. What is the cell?
I mean, I don't know how to explain, but
You better be, because you will become a nurse. Your patient needs explanation, and your patients will going to ask you
So-
all these questions. You have, of course, to be on them, to be their level, in order to be an effective nurse. Sad to say, yes, we are nurses. That's why I'm always so curious, of course, to know how to explain it to me, because I want to hear it yourself, so that if we could modify the way you explain your concept. And that's my role here, isn't it? So again, explain yourself.
oh, okay.
Okay, I'm your patient. Miss Avani, what is HIV? Do I get it if somebody's HIV to me?
No, if you have an infection or cut, and then if you are that time, if person saliva or any mucous membrane.
So again, you have a cut on your finger, and again, your patient was HIV positive, sucked on your finger. Is that correct? You mean? So what kind of person scenario in the real world? Or give me your finger. Yeah, did that one to you?
It can be.
It could be. But would you believe, of course, that your percentage, even if you stuck with somebody who's not only HIV, but has already progressed to AIDS,
Yeah.
is only 0.1 over 1,000. It's only 0.1%. Okay. So again, if you are stuck, are you free from HIV? You are 99.9% will be negative. Only 0.01%. 0.01%, 0.01% negative. Positive, your probability, of course, will be 99.9% negative. Okay? Even with your post-exposure prophylaxis. That is why we don't fear HIV. U.S. standards does not fear HIV. There is a regular guy. And that's the first place, if you are doing somebody with HIV cannot survive outside the host.
Yeah, that's
Okay?
the thing. Host, yeah.
When we speak of host, not only talking about host cell, but of course the body of the
Yes,
patient.
yeah.
Okay? What's that? The HIV cannot survive outside the host. Take a look, of course, on your hepatitis B. Ario, don't you know, of course, your hepatitis B virus could survive at least a week, even in the surface of the table. So HIV, when of course somebody ejaculated because again they ejaculate, the semen has of course HIV. Once you are out there in the world, sorry son, you're born without a mother. Thrown of course there of course in the board. And again the HIV, all the HIV there are also dead. Okay? So that's why we don't fear that much. And again, your probability of getting HIV in the workplace is way soon. The only problem is you have having sex with your patient. That's a different story. But as a clinician, you don't do that one, isn't it? You don't offer sex therapy. You said, oh, by the way, I'm a nurse. At the same time, I'm a sex therapist. Don't worry, first lesson free. Okay?
Oh, is attached with the T cell and to become a
Well,
host,
that's why
right?
we're going to figure it out. I want to put the
ST
basic
cell,
concept,
yeah.
what is, of course, your HIV. Yeah? So HIV, welcome. So this is, of course, your human immunodeficiency virus. I will be fast with this one. I want you to get, of course, the core of what is HIV. Okay? So meaning to say, how would you acquire HIV? Okay, where would you get it? In the workplace, believe it or not, your risk of developing hepatitis B is way higher, 100-folds, than getting HIV. Okay, and again, in your hepatitis B, as a healthcare worker, I would recommend to you, with me, I have of course to know my titer because I will be working with patients with blood every day. Okay, so I'm always exposed every day each time we work. Therefore, I have to know my hepatitis B status. So I should be negative for antigen because I was not infected, but I want to know my hepatitis B surface antibody. And your hepatitis B surface antibody should only develop if you are vaccinated and you converted to develop your own IgG against hepatitis B. Okay? So remember, if you are greater than 10, it means you are positive. Okay? And then greater than 100. And so now I converted. So again, meaning to say I could protect still myself with hepatitis B. But does it mean, of course, because I have antibody, I cannot get hepatitis B? I could. Especially, of course, there will be a lot of ways. Remember, vaccine antibodies are not guarantee for you to have no infection of the specific thing. It can help you prevent because, again, your system is equipped, of course, with a defense that could correct right away, that could fight the infection. Okay? But HIV, right now, there's one vaccine that's being presented with to be given, okay? But again, it's not yet approved for HIV. Okay? So again, here, HIV is, in 1980s, was first seen unusual infection in homosexual men. Oh gosh. If you are gay, and you are practicing gay, then probably will develop this one. Okay? Because there could be a gay individual, or you can say, I'm gay, but I'm not practicing. So you're gay probably in words, but not in deeds. Okay? So it could be the different thing. That's why a practicing gay individual, okay? So especially men. So, but again, it was observed because, of course, of the transmission. So because of that, it's manifested, and in 1983, the virus was identified as your HIV-1. Okay? The Food and Drug, FDA approved the HIV diagnostic test, meaning to say the first diagnostic test that we do it will be your ELISA. What's ELISA again? Enzyme length immunosorbent assay. Isn't it? Right now, the term ELISA is no longer used anymore. It is used, of course, as your EIA. Okay? So that's one thing. Since the time that this is reached pandemic proportion, meaning to say, in any part, of course, of the world, there is HIV. Okay? I just talked, of course, to my friend who is a provincial nurse in my province of origin, and then she told me, of course, of the height of the increase of HIV positive in our island. Okay? The CDC, in the National Center for HIV, STD, TB prevention, maintains a comprehensive health care. And again, the CDC and your National Center for HIV are the two centers. You can research online for any updates with HIV. Okay? They're the one that publishing all those official statements about HIV developments or updates. Okay? So, in other words, HIV, we have, of course, opportunistic infection, and cancer accounts for a large proportion of death. Okay? The question will be, could HIV kill you?
Yes.
The answer is no.
The infection.
And another question will throw to you is that how would you differentiate HIV from AIDS? Does it mean, of course, that Magic Johnson has HIV, he has AIDS? Magic Johnson is still labeled as HIV positive, never have AIDS. Okay, so this one, of course, of the objective thing, how do we differentiate? Because again, believe it or not, even in healthcare, we do, in nurses, not all nurses have a good concept of this HIV. It is a very hot topic that we are talking about. And again, one thing is that the first question, you have to know in order to defend yourself, isn't it? But actually, as a clinician, as long as you don't do, of course, below the belt thing in your patient, you don't have any fear much of HIV. Okay? You have to fear hepatitis B than HIV. Okay? TB, yes, of course. Me, I'm not afraid of TB. I don't know why, because of course, because I'm busy vaccinated, but plus the fact, of course, I said, oh, I know I'm BCG vaccinated. I told, of course, my nurse, our company nurse, could you test me again? I want to know if I'm HIV, I am HIV positive. I am TB positive. TB positive. So I did one too. I don't know why we're going to go away. But in the end, oh gosh, 24 hours after, I start itching, developing big induration. Right now, I still have, of course, I want to show you, okay? The remnants, of course, of my monkey test. It's getting decaying right now, but again, I said, oh gosh, I'm positive. So again, I told them why I will turn, of course, negative, but indeed, if you are develop antibody, it means already that you still need to be positive. Okay, you convert, once you convert, we call it 1-0 conversion, definitely you keep, of course, an antibody. Any one part of your antibody, a memory copy, then it could produce, of course, 1,000,000 ones. Okay?
Mr. Leary, I got a question.
Yeah, sure.
Not once you take the main two tests and you're positive, if you take it again, the mark get bigger and bigger on your arms?
Why do you have, of course, to take the step 2 if you have already been positive?
No, but a lot of people, they're in denial, they don't accept the fact that they're positive. So they believe that when they do it again, it's going to be negative. But that's why they always say, that's why we always tell them, you don't take it, once you're positive, you're not going to never get negative. But when they take it, it gets, the circle gets bigger.
True.
Why
Because
is
again, because you presented the antigen.
that? Okay.
Remember, the response will be as long as you present the antigen and antigen again, you're expanding the response of the immune system. Antibody is only being reproduced and cloned if you presented somebody with antigen. So meaning to say, my IgG against TB right now is very activated because it was presented with this antigen. So next time, I'm going to do that one again. The response will be not that small. It will be big, of course, as $5 bill, probably. Okay, because of the fact that that antigen already stimulated the production of IgG for TB. Okay, very good question. Now here, HIV will not kill you, and again later on we'll want to go to the definition of HIV to AIDS. Okay, only opportunistic infection will gonna kill you. The most common one is that even the newest signs of the infection, even colds, could kill you. Okay, because your immune system is totally down. Okay. Since the main opportunistic infection, watch out for this OIs. OIs or opportunistic infections. These are the infection that will gonna infect the individual if they turn to be HIV positive. Okay? Since of course medication called antiretroviral therapy exerts a profound effect on the progression of HIV. Do you have medication for HIV, isn't it? But it's not of course to kill the virus. Okay? It only blocks the reproduction. Or replication. The term will be replication. So if you block them, meaning to say that they cannot reproduce more of their copies. Because of that, definitely can create much damage. Okay? But do they go away? Although we know that when of course the HIV is a retrovirus, we know that most of the virus is that when they infect a human body, after they infect the human body, they exit. Or they exit, of course, the human body, but not this one. They stay and they linger, just like your shingles. Okay? So because of that one, the effect or the progression from HIV to AIDS of a lot of people, of course, has been delayed. Individuals who take, of course, this medication often see a drop in the amount of circulating virus in the restoration of the immune system as measured by the T cell count. Medication therapies have resulted in a significant decrease in the frequency of the OIs and the number of deaths in the person infected with HIV. Okay? So HIV is an infection, human retrovirus. Okay? Common invades, again, sad to say, both of which the T cell, of all the cell of the human body, that this HIV, this retrovirus, destroys or attacks their host wanted to be, and their favorite host will be your lymphocytes. Both your B and your T lymphocytes. And because they are viruses, they are RNA form. So what they do is that they use the biomechanisms of this T lymphocytes and B lymphocytes in order to reproduce themselves. Okay? HIV specified, of course, depletes the helper T4 cells. Again, the favorite cells attacked by HIV. T4 lymphocytes. So what does the T4, also known as your CD4 lymphocytes, what does the T4 lymphocytes role?
To come and fighting.
To go back again, what's the helper T4 cells role in the immune system?
Initiate the pathway.
So if you destroy your T4 cell with HIV, take a look for that one. Who screams? Who declare that there is infection? So that is why HIV considered them to have, of course, a PhD, of course, in infectious mechanism because of the fact that they infect, of course, the cells that augments, that initiates the infection process. Therefore, definitely, our body doesn't even know that we are infected. Why? Because, of course, they infect the cells that starts, that initiates, that screams that there is infection. So that's so bad, isn't it? Therefore, if there's an infection, take a look for that one. The TB cells came into you because you are HIV infected and your T4 are depleted. Who screams that there's a TB infection in the lungs? Nobody. Then the TB could have get problem. Oh, it's happy days. We have always a party here. No securities. Okay? No securities, no bouncers. Oh, let's go. Enjoy.
No police.
So because of that one, again, they proliferate and they could destroy, before you knew it, they destroyed already the entirety of the lungs. Okay? This is the mechanism, of course, in HIV. As a direct consequence of the invasion, the individual vulnerable to many opportunistic infections, those caused by microorganisms that usually does not generally person, even your pneumocystis carinii and pneumonia. It is a protozoan. If you're healthy and your immune system is okay, it is just like a nuisance form of microorganism. It can not even inflict any damage on your part. But because your T4 is down here, definitely even your pneumocystis carinii or pneumocystis jirovecii that you named for that could cause a massive damage to the lungs. causing, of course, your immune system carrying anymore. Okay? Okay, that's one thing. And again, if untreated, HIV depletes the individual's immune system over the number of years, allowing development of both minor and major opportunistic cancers, eventually leading to death. So again, what kills the patient?
Infection.
Opportunistic infection, not the HIV. Okay? So in the untreated person, the average time from the HIV will be 10 years. So again, from now, if you're going to surface that one, if you have, of course, developed that, okay, then you lose 10 years. HIV is not curable, it can only be treated. Because again, we could contain the reproduction capacity, of course, of the virus. Okay? HIV is transmitted through what? Infected body fluids by the following routes. Unprotected sexual contact. Okay? I remember, of course, in the Facebook, I found, of course, just a few days ago, it's a very, very funny caricature. It's a funny clip, video clip. There is, of course, a drawing, a vandalism, of course, in the washroom of penis. Okay? It's just that one. It's so cute. I like it. I like it. I like it very much. You know, the sudden, it's a protection thing. It's a protection thing. That's one way of advocating, of course, safer sex. And then this guy, of course, is that he's looking for a vagina. It's a picture. It's a drawing of vagina, and then a penis in the vagina. He went, of course, closer to the vagina, and all the vagina went and then get away from him. Okay, all, of course, of the drawing in the washroom, in the bathroom, in the public restroom went away. And later on, if you can see that one, if you could share that one, it's a funny one, and it has a very good impact. Again, he was so tired, of course, of chasing women. And then he went, of course, it went closer to a real woman who, of course, putting lipstick, of course, on herself. And then the real woman know the problem. You know what? He drew, of course, with a penis. He drew a condom. Okay? When he drew a condom, then comes the women. Everybody wants him. Okay? So that's the thing, the only one he wants, because again, all the women are so afraid because he's bare. Okay? And once he's got the condom, then he got, of course, all the women, and then he got so tired, of course, of the women. Okay? So that's one thing, is that it's one, of course, of safer sex. That's why right now, even schools, even in elementary grades, if the children starts to be active sexually, we advocate, of course, the use of condoms. If we cannot beat them, we keep them safe. Not we join them. Huh? If we cannot beat them, we keep them safe. That's why right now, even a nurse, if the child, of course, who is sexually active, could ask from the nurse, we have some condoms, the nurse is obliged to give condom to the child. Okay? It is, of course, we are advocating safer sex. Okay, that's why when we're talking about sexual contact, it is vaginal, oral, and anal sex. Because again, in those forms, we could be exposed, of course, to the open wounds, or shall we say, to the blood endings, of course, of our human body. Okay? Share infected needles, especially if the needles has already inside it, and you share it, accidental exposure to infected blood, but again, your exposure, infected blood, not your needles. Okay? From an infected pregnant woman to her fetus will be possible. This is one, of course, of the greatest trending, of course, that the babies are born out of infected mothers. Okay? So these are the things, of course, and again, usually we get it from your body fluids. Especially the most common body fluids that we got will be, that has a lot of it, will be what, besides your blood, will be the cervical mucus, cervical secretions, and your semen. Okay? Could it be shed in breast milk? Yes. That's why an HIV positive mother is not advised to breastfeed. Okay? So that's one thing. And again, of course, accidental exposure, but again, primarily HIV, besides this form of transmission, is primary sexual. Okay? So again, be, of course, with your sexual life, be responsible, of course, in conducting it. So another one, of course, this one, a group, of course, of babies who are born out of mothers who are infected with HIV. Okay? From infected mother to her child through breastfeeding. It could be, in 1985, blood transfusion was associated with HIV transmission, but right now today is HIV free. So we do, of course, ELISA testing for all blood donations. Okay, therefore we are HIV negative. Transplant donors, for example, before, if you get a kidney, in the kidney, of course, of that individual is HIV positive, therefore you will get HIV. Okay, so transplants will be, of course, screened also, of course, for HIV. Women, teenagers, persons older than 50, again, especially women, teenagers, older than 50 years are currently among the fastest growing. Again, it is not the homosexual men. It is not the women and teenagers, both sexes. Because, of course, of the practice, of course, of sex. Okay? That is not protected. Another one, of course, is that 50 years of age, oh gosh, you are menopaused already. Okay, so you are using Viagra already, but still, you are still very active. Okay? So sometimes we are using, of course, from CVS, Astroglide, okay, or KY. So from the Filipino people, if you don't have KY, you use Laway, okay? So, or your saliva itself. Intersexual transmission of HIV increase across the ethnic groups. And right now, the first case, of course, of HIV is found where? In Africa. Okay, in the Republic of Congo. The HIV, of course, usually, of course, believe, of course, that, again, it was from a monkey. The question will be is that, what, monkey? Therefore, if HIV is HIV, of course, a sexual thing, the man has a sex with the monkey?
Who knows?
But no, because of course of the fact, research says that some of these people slaughter the monkeys. And because of that one, it's not with the sex, but again, because they slaughter the monkeys, and sometimes they have their own wounds when they slaughter the monkeys. And because of that one, they were exposed to this monkey, which is HIV-1. Okay? It cross-contaminated, started with the monkeys, it contaminated, of course, the human being, but not through sex. Research shows that it is because of the fact that there's some practices there, they slaughter monkeys, and then they do it with bare hands. It so happened that if you have open wounds and cuts when you do that one, then you could have, of course, the HIV access. You ask them. I don't know. Good question, isn't it? Good answer, isn't it? I don't know. But it evolved from there. Because again, always remember my thing is that, especially in microbiology, always remember this thing. In infection, microorganisms were created ahead of us. Okay? They were being created, of course, ahead of us, or shall we say, of course, in a scientific perspective, they were here, existent before us. Okay? Because of that one, they are also organisms, and they will assert their stay here on this earth. Because of that, as a human being, your role there is to pay respect with this microorganism. Whether you like it or not, they will gonna strike at you, and they will gonna persist to live in this world. Okay? And the only way, of course, to show respect to microorganisms is to make sure to accept that reality that they could kill. Okay? And one way, the most common gesture, of course, of respect to this microorganism is always to do a frequent hand washing. Okay? So because you're going to beat them. Whether you like it or not, take a look for the one. Before, we have only a plain streptococcus. Okay? Give penicillin for them, they're gone. But take a look for that one. Did we beat them? No. They develop, of course, resistance to certain organisms. We have MRSA. Okay? Right now, we get with this MRSA, with these people, with these microorganisms that are so potent, we give, of course, another medication that is so potent, vancomycin. What shall we do? We develop another group of organisms, vancomycin-resistant organisms, VRE. Another group of antibiotic we use, we develop ESBL. Right now, the highest one is that we have organisms already that are resistant to at least 2 forms of antibiotics. We call them multi-drug resistant organism, MDRO. That's one of the greatest fear. Because again, our usual antibiotic cannot kill them. That's why our antibiotic right now is first generation, second generation. We are doing third and fourth generation of antibiotics because we cannot beat them. Okay? That is why, in terms of disinfection, of course, I would like, of course, for you to take a pause, of course, and think about that. One of the greatest important health teachings that we give, of course, to the patients, especially antibiotic, is that respect the microorganism. Kill them. How do you kill them? Complete the course of your antibiotic. Clear. And plan again. Okay. So because of the one, let us pause, of course, for a break. Okay. And then when we continue, it's primarily sexual. It could be transmitted from the mother to the baby during pregnancy, as the same is true during breastfeeding, blood transfusion before. And right now, the sexual transmission of HIV is increasing across ethnic groups in assorted places. Okay, so what are the signs and symptoms? How would you know that you have HIV? Can you develop HIV? Okay, so usually persistent, again, one, just like inclusion lymphoma, just like your Hodgkin's, persistent lymph nodes enlargement, that's one. Fever, night sweats, diarrhea, those are the weight loss, oral thrush, because of the fact that your system has already been affected, and usually the primary cell that is affected is your CD4 lymphocytes. And we know that your CD4 lymphocytes, or your T4 helper T cells, is the one that initiates your inflammatory response, your immune response. Okay? So usually these are very, very vague, as a matter of fact. So therefore, the only thing, of course, that you will know, of course, is that if you're HIV positive, will be to test the individual. Okay? Sometimes it could be developing herpes zoster or shingles, although there are some people, of course, has been asymptomatic for many years, and person who do not tested may not know that they are infected. Okay? And believe it or not, there are some people right now, a segment of the population, that they have HIV in their system, but again, they didn't progress to AIDS. Okay? Because of the fact that still we don't know, but the system can tolerate the process of HIV in their system. These are the group of individuals right now who is, of course, being the subject of research, wherein what causes them to tolerate the process of HIV in their system. Okay? It does not show that their immune system is totally destroyed. Therefore, primarily when we speak of HIV, the greatest fear we got is HIV will destroy the immune system. Thus, if the immune system is destroyed, any possible infection could be an indication. Okay? So, women generally experience gynecological problems. It's a clinical manifestation. That's one thing. And then sometimes you will be just having recurrent vaginal infection, menstrual abnormalities. Sometimes there might be, of course, abdominal practice, cervical cancer. Okay? So these are of course, the manifestation. So it's very generalized. That's why we call the HIV, later on when we speak of progressing, it's a complex. Okay? Because of the fact it's a syndrome, because there is no specific, of course, manifestation. But again, to have HIV, it could be, those are of course the manifestation, but nevertheless, how does the HIV differentiate from your AIDS? Okay? So these are the manifestation. You can just read through this one. So again, most often, this will be affecting the constitutional status, meaning to say there might be some wasting, weight loss, there might be some diarrhea, and most often there is a process of infection. Whether the infection could be another viral infection, could be a bacterial infection, could be fungal infection, could be protozoal infection. Okay? So it could be up to the point that if HIV cannot be managed properly, cannot be treated, then it could be, of course, the latest one, HIV encephalopathy. Therefore, HIV could cause dementia. Okay, we call it what sure, AIDS dementia complex. This is the last stent we're in. HIV was able to navigate through the brain, thus causing damage to the brain itself. Okay? One is that in the skin we're going to see, of course, changes. One of the most common changes in the body, of course, of the individual having developed HIV/AIDS will be your Kaposi sarcoma. Okay? The Kaposi sarcoma is a form of cancer that usually observed only for people who have HIV/AIDS. Yeah? So how do we test the individual for HIV? First one is that antibodies to HIV develop in as little as 3 weeks. So if you have sex last 3 weeks ago, and your antibody could be checked right now. Okay? Up to 14 months after exposure to the virus. And again, lifetime of this patient, after of course the manifestation of the disorder, will be around only 10 years if it is not treated. Except for those people who could resist the process of HIV. Okay? We call them non-converters. Okay? So the person can have false negative result for the virus during this time being. Okay? And again, we have of course to check, and sometimes we have the preliminary test, and later on we have to confirm that indeed it is HIV. Okay? First one, enzyme immunoassay or enzyme linked immunosorbent assay, or EIA, is the first screening. Okay? What does, of course, the enzyme linked immunosorbent assay means? It means that, what are we testing here? I know, blood. It could be, of course, but most often when we speak of EIA, we could do blood. Right now we could do, of course, oral tissues, or oral sample. Or in the later form, which is the less accurate, will be urine. But here in the blood. But again, what do we test there? What do we want to find out?
Antibodies.
Antibodies or antigen? If I'm going to say, tell you what is HIV antigen. What are antigens? So what is the difference now, HIV antigen and HIV antibody? If I'm going to tell you, you are HIV, you're HIV antibody positive. Do you have HIV?
No, but you have
Okay.
antibody.
You have the antibody.
What type?
So what is the great difference between HIV antibody positive and HIV antigen positive? And that's a very, very good example because I wanted to understand that. Because it could occur that somebody could be HIV antibody positive, but HIV, we want them to be HIV antigen negative. Okay? An HIV antigen positive are the people antigen positive. Okay? I use the word AG positive. Are the people who had the virus in themselves. Okay? So if you are labeled HIV antigen positive or just HIV positive, it means you have the virus in your system. Clear. Because of the fact that you have the virus in your system, you will eventually be tested after 3 weeks to 14 months. You will be developing to have to be an HIV antibody, AB positive. Okay? Therefore, all individuals who are HIV positive or HIV antigen positive are HIV antibody positive. Do you get it? Because your body will develop antibody against HIV. The only problem later on for that one, this is the virus. Our antibody cannot contain HIV. They are so small, and usually only one RNA of this virus enters one of the CD4 lymphocytes. That's the end of it. Okay? Now my question will be, could a patient be HIV antibody positive, but HIV antibody negative, antigen negative?
Well, I think we have to get the antigen in order to develop the antibodies, right? So if you don't have the antigen,
You cannot have an antibody.
Therefore, you said that if somebody has HIV antigen negative, they cannot be HIV antibody positive. Very good. How about the babies, the pregnant women are pregnant? This is the status of the babies we want to have.
Oh, yeah.
Okay? If you test them for ELISA, a newborn, who get out from a mother who is HIV positive, again, the term I'm using, HIV positive, it means it is HIV antigen positive. If I'm going to say HIV antibody positive, that's a different thing. I would like to emphasize the antibody. Okay? In this, we want this one. That is why in women who are pregnant, who are HIV positive, definitely they are HIV antibody positive. Then again, this antibody, remember, this is antibody, this is IgG. Could it cross placenta?
Yes.
Yes. Therefore, a baby who is born out of a mother who is, of course, HIV positive are antibody positive. But the question will be, if the baby as well as HIV antigen positive, this is the end of the world. These are the babies who are HIV positive. Our goal here is that to contain the mother's viral load later. I'm going to talk about that one. In order the baby will be born, yes, HIV antibody positive, but HIV antigen negative. It means that no virus transferred to the baby. If this is the body of the baby, and remember, this is a passive form of immunity. Because again, the baby got the HIV antibody, not the antigen, no virus, only the antibody because again, it is transmitted to the placenta. Okay, do you get it? This is not the virus. This is the antibody that the mother produced against HIV because the mother is HIV positive. Therefore, if the baby will gonna come out, what will happen to the HIV antibody that the baby has? It will just die away because this will not stay in the system of the child because this is the mother's antibody. The baby has to produce his own antibody when he's independent. But at least the baby doesn't have the virus. We do not want the baby, the fetus, to have the virus. That is the goal in mother's care. In right now, of course, in Africa, our primary target, we're in the incidence of course of the HIV is very high. A lot of women who are HIV positive, okay? Let's imagine. This will happen if the mother didn't get any treatment. That's why when the woman is pregnant and the woman is HIV positive, right away we have to give medication. And the first medication that's been developed against this one is your sidovudin or your AZT. Okay? This is your Ritrover or AZT. Okay? Or because of that one, take a look for this one. If the mother is HIV positive, of course, in that way HIV positive, the chances of the baby to get this HIV antigen positive is around at least 20%. Think about it. For every 10 babies or for every 100 babies born out of HIV antigen positive mothers, almost at least 20% or 20 babies out of 100 will be HIV infected. Do you get the sequence? This could go up to 40 to 50%. Okay? The list will be 20%. So just imagine 20 babies or make it 100. 20 babies out of 100 pregnancies will lead them, of course, to be. And this baby will grow old. They will die young. Okay? So our goal then is to push. Again, here comes the CAZT given to the mother. Okay? Right now. Okay? For every 100 pregnancies, less than 2 babies will turn out to be positive. For every 100 babies, almost less than 2 of them will be pregnant from 20. That is why the goal here of care in pregnant, I would like to emphasize this one because it's a very important thing, of course, that we are pushing right now here in the States as well as in other parts of the world. Start treatment. This is the priority. This is the high-risk groups. Because again, you don't blame the baby. The baby doesn't have any food of its own. He was just pregnant. It so happened that, of course, the house that she became pregnant is infected with this one. Therefore, we have 2 patients here, the mother as well as the baby. And we want the baby to be HIV antigen negative. How do we do that one? Antiretroviral drug during the pregnancy. The risk for giving this one than nothing at all is very high. 20 out of 100 babies at least, but commonly in statistics right now, it went already to 35 to 40 babies for every 100 pregnancies. Okay? So give them sidovudin, only less than 2. I'm at 1.7, but we cannot cut, of course, the baby into 1.7. So there will be 2 babies, less than 2 babies in 100 pregnancies. See the statistics? So we need to say from 20 to 30, only 2. Okay, that's why we advocate this one, of course, this management on this. Yeah? That's the thing that we're going to answer for you later on in my videos. Okay? In the book, if you read, of course, the book, we have your nucleoside NRTIs, nucleosides reverse transcriptase. Okay? Inhibitors. We call that one NRTIs, and your NNRTIs, non-nucleoside transcriptase inhibitors. Another one which will be that will be the first round. We have your protease inhibitors. We have your entry inhibitors. All these medications, of course, are there in the market. Again, right now, the approach will be give a cocktail. A cocktail is a combination of medication, antiretroviral drug, so that to make sure that the virus will be very low. First one is that diagnosis first. Okay? Here we are testing your antibody. You're correct. And in EIA, it is not conclusive because we are testing only antiretroviral antibodies. And we have a lot of retroviruses. Okay? Therefore, is it HIV that we're testing here? And most often, the most common and the most of course, invasive retrovirus is your HIV. So if you are positive with EIA, it does not mean 100% you have HIV. We have to make sure here in your Western blood test, which is less specific than Western blood test, that we want to point out that indeed it is HIV that caused the rise in the retroviral antibody. Okay? Seropositive testing, more specific and specific the EIA, what we want of course to know here of course that the question in AIA, positive urine, positive in AA, the question is that, is it HIV that caused the antibody development for the retroviral? We have to go of course in your Western blot to confirm that indeed it is HIV. Okay? But still, the question for the one is that we are checking of course that indeed you develop antibodies still against HIV. Okay? If you are an adult, that you are HIV antibody positive, where the hell you get it? Are you still a baby? Your placenta, you came from placenta. Therefore, any adult who tests with Western blot who will develop antibody against this one on their own are primarily the only way for you to develop HIV antibody is to have HIV antigen or the virus in you. Okay? But there are some group people who are HIV antibody positive only for babies because they are receiving, of course, from the mother. Okay? So that's one thing. So we have some other testing, of course, that you can perform. So that's testing. Again, I would like to emphasize EIA or ELISA screening for antibodies against retrovirus, not specific to HIV. So if you are positive, if the patient is positive with EIA, it has to be confirmed. What is the question? Is it antibody against HIV? That is the question answered by your Western blot test. Clear? Because in adult, again, if you are of course positive with antibody, it means you are being exposed. Whatever of course the exposure will be, that is of course the thing. Okay? So in other words, your viral load. Okay? Viral load determines the strength of the virus. The question is in your viral load will be how many copies of RNA are in your system right now. Always remember, the more RNA, the more copies of the virus in your system, the more damage they could create, the more CD4 lymphocytes they could damage. Clear? They could kill. Okay? So viral load is determining, of course, that what is your status, how bad, of course, is the virus will be. Could the virus be contained? It means to say the population of the virus could be told with your viral load. People tested, of course, many legal implications to the laws for this one, okay? But the most important thing for that one, the question of viral load is that, do you have a lot right now? So the question will be, the goal will be, because we cannot eradicate HIV antigen in your system, or virus in your system, we want, of course, to contain them. Therefore, the lesser viral load you got, the better you will be. And usually, if you are being given an antiretroviral drug, so shall we say you started with 500,000 copies, because it could reach 2 million copies, okay? And we started you with cocktail, AZT, or Sandimune, all these things, of course, a Virusept together with that one. And all of a sudden, your viral load went down only to 100. Is that retroviral drug effective or not? Therefore, viral load is also means way, of course, to monitoring patients who've been started with antiretroviral drug, if it is effective or not. Okay? So the question will be, the most common is that if two individuals, okay? And again, this one is that the viral load is that the more you have viruses in your system, the more you could contract it with other people around you. Okay? So like for example, if I have 1 million copies of the HIV in my body, and again, I am gonna sex with somebody, okay? And again, they don't have one. Therefore, my capacity to infect an individual because my viral load is high is way higher as compared to somebody who has HIV who has only 10,000 copies. Okay? The question is, it is a blowjob and there's nothing, of course, in the throat. So again, it goes, of course, in the hydrochloric acid, which will gonna die eventually right away. Okay? So that's one thing is that if you have cavities, don't do blowjob. Okay? Make sure that your cavities are filled first before you do that one, just to make sure. Okay? That's a very friendly advice. I'm sorry, but I'm so homosexual, Miss Marcy. Okay? Because of the fact that this is sexual in nature. Okay? But again, I'm advocating this one because I want everybody to be aware that only nurses, especially you, because what we're going to do, of course, is to educate patients. Yeah? So because of that, the viral load is determining the virulence, the strength of the virus. Therefore, a patient who has higher viral load is more contagious than somebody who has lower one. Okay? And by the higher the virus you have in the body, the more damage it will create. To what cell?
T cells.
To be specific,
T or B.
CD4 lymphocytes. Okay? We can count them, CD4 lymphocytes. The more damage to the CD4 lymphocytes, the higher the risk of the patient for infection. Okay? Do you get the correlation? That's the basic principle. How do we understand? Now I go to the question. The husband is positive with HIV. The wife is also positive with HIV. When they go in sex, do they need protection? Or what the heck is that? They are all positive with HIV. Why? Okay, go ahead, swallow whatever you need to swallow, and then don't go over everything. Could we advise them to do so? Why the heck, of course, that you have, of course, to do safe sex because we are both HIV positive? But again, do we do that one, or do we encourage that one, or we tell them, no, you have to use safer method, just like condoms. You have to use condoms, even if you're husband and wife. So what would be our recommendation? Forget about it. Enjoy. Okay, is that correct? Why, if you were going to recommend condoms, why the heck would you recommend condoms then?
For the viral load of the
What do you want to prevent? Infection? There is no such thing as reinfection. If you are positive with HIV, you will die as positive with HIV. There is no such thing as reinfection. Then explain yourself properly. I'm listening. Why? Very good. This is the concept of your viral load. What if the wife has only 5,000 right now because she's drinking her medication? The husband forget about he's drinking alcohol, and he got a viral load, of course, of 600,000. They sex together, and again, therefore the semen of the husband has a lot of viruses. Therefore, you alter the system of the woman by putting a lot more viruses. Do you get the difference now? Therefore, for HIV individuals, if they have sex, even husband and wives, we still recommend to not alter the viral load. The higher the viral load, the higher the capacity of the individual to inflict infection, plus the more damage to the CD4 lymphocytes. Therefore, our goal now for an HIV positive client is to push down the viral load to 0 level. Okay? But even if you have 0 level, very good response. Even if you have 0 level of viral load, it does not mean that you are negative with HIV, because they are inside the cell. This testing for viral load is only outside in the blood.
So in a situation where one person has it, the other person does not have it, what happens in that situation?
Oh, simple. Semen, what's God? The woman or the man? Or is it the man and the man, or a woman and the woman?
The woman had it and the husband didn't have it, so.
Simple. Again, they have sex. Is it anal or vaginal? Regardless. But it's again, it's vaginal sex. I'm just kidding, okay? Take a look for that one. When do you engage in sex, okay? Because of the volume of viruses in the cervix, in the cervical canal of the woman, when, of course, the man ejaculate and open, it could penetrate, of course, the urethra and invade the system. That's why men who have sex with women who have been infected with HIV, right there and then, you got even just one HIV virus was able, of course, to traverse through the urethra of the man. It doesn't mean that you have the penis of the man and the penis will gonna pep always. The virus could go inside as well. Do you get the point? You expose the man with, of course, the volume of the virus that are too much, that can penetrate even, of course, the urethra of the man. What you end up, it will gonna go to the man's system that's infecting the man.
But this is a situation where the wife was infected, but the husband was never infected. And actually the wife ended up dying, the husband is still well, but he's not infected.
One have AIDS, one have
I'm just wondering how it
Did I ask, did I said earlier that some people, of course, there are some group of people that can tolerate the presence of HIV? They are seroconverters. There are the group of people, again, to go back earlier, as I have said, these are the research of the people that we're pushing right now for HIV advancement. Why the heck, there are some group of people, there are selected few, why the heck they do not have developed HIV/AIDS? I don't know, it's genetics. This again, hopefully some of you here will be having your PhD in microbiology or your PhD or what you can advancement in research. Hopefully some of you could crack why is the reality is indeed there are a group of people even exposed to HIV does not develop the infection. And these are the group of people that I'm saying earlier. They are the subject of research. Why? Could we get the resistance of that individual and put it to another individual? That's the biggest question right now in HIV research. For now, the only effective thing that we know is give antiretroviral drug to keep the patient's CD4 lymphocytes up, or else he will die. Okay, go ahead. Are you talking about the people that you know? I know. See, that's a real life because that's the passion, of course, in asking the question because you know by heart what the heck is happening here. Okay.
Yeah, another question. Does the circumcision have to do with the protection or just the
Circumcision is only for hygienic purposes. Okay. Or probably some part for the one probably aesthetic purposes. So just like, oh, cut the peel. I want to eat my banana peeled off. No, just kidding. It's only for hygienic purposes. Because again, why to go back to the reproductive system? If a man, of course, is uncut or uncircumcised, there's a probability, of course, of buildup of smegma inside, of course, the head, of course, of the penis. The higher, of course, the smegma below there, or the harder, of course, of the dirt, the higher the patient's, of course, chances to develop penile cancer. That's the only risk, hygienic purposes. Is it for erection? Therefore, is that if you are uncut, you are stronger than the cut? Because the cut, of course, some of it? No. The answer is there's a fallacy. Okay, do you, quote, uncircumcised individual cannot bore a son or a daughter, of course, to a woman? Forget about her. They have sperm. Okay? So those are the fallacy. The main reason why we do circumcision is primarily for hygienic purposes. Not only that is, of course, the clinical side, in most often religious purposes.
No, I'm just wondering because after the epidemic in Uganda, so many people died of HIV, and so they started encouraging people to be circumcised. Those who are not circumcised, So I thought maybe it was helpful for them.
It is because of the fact, of course, if you are not circumcised, your tendency, of course, is that you have a fold, of course, of skin around, of course, your head. And when it inserted into the vagina, after the one, if you are exposed with the cervix, if you didn't wash and pull out the prepuce and then wash the skin, there might be, of course, a good area, of course, of a cervical mucus that contained the HIV. Then again, you didn't wash your pee-pee, then you sex again, there's a lot, of course, there are possible HIV, cross-contamination. And I agree with that, hygienic purposes. Okay? Yes. Okay, I love to hear these questions, okay? Because it's real life one and real observation, yes. Mm-hmm.
There was a doctor who was interviewing like the prostitutes.
Mm-hmm.
They never get HIV.
Who?
I don't know, like people that have sex with the sex workers, the prostitutes. They never got
Prostitution is the first profession, is the oldest form of profession.
They never got it.
It's older than nursing, just to let you know, okay? These are another group of people, Ms. B, that are non-converters. So these are the group of people, both of that one and this guy. I don't know the question for me. My question is that I always blame it. Is it genetics? What portion of their blood could resist the HIV? Why they don't suffer the manifestation of HIV? Now, for example, for this one, they might be infected, but why they don't die with HIV? Why only the partners that they have sex got the HIV? That's the question. Because they don't convert, they don't develop, and they don't suffer the effect of HIV themselves. Even HIV is positive with them, inside them. And again,
No, they tested them because there was a doctor who was advocate.
mm-hmm.
They tested them and all the prostitutes were negative.
Wow. Even they have sex with positive individuals.
With the medical
Bring them here in the States, we're going to research them. Okay? I want to know them. That's why if I have some time, that's the area I want, of course, to invade in research. If I have some time for doing research in the future, if I have, will be given a chance. It's a very interesting. What the heck? Is it, of course, the gene? Is it, of course, what component of the blood that we don't know yet at this point in time? That it could resist the process of HIV. Okay? So very interesting topic because, again, this is the reality of it in the world. Okay? So, again, right now, you cannot say, hi, Mr. Jones or Sibadu, you're fasting with HIV. I'm calling you that. We cannot do that one. So no over the phone, okay? No over the phone. And again, I cannot get. Gosh, I'm working as a nurse. I pricked myself with the needle I used to you. Okay, here it comes. Veronica Parker, I'm gonna go some blood from you. Send it. Test for test, of course, for AIA. Who positive? Who? Oh my God, of course, HIV. You're gonna test somebody's blood without their consent. Nurses could do that one. Isn't that? We could pull it right away, but you cannot, by law, you will be, of course, your license, of course, will be extended. Because it has to be done with consent. Plus, if you are testing somebody, they should be referred to a government-approved counselor. Okay? That is supposed to be, even if they are negative, they should be referred to. Much more if they turn out to be positive. And again, all the records that you tested for HIV individuals, okay, should be reported to CDC for statistics purposes. Okay? So we will know who are positive in this area and how many guys are positive. Okay? For the purpose, of course, of the progression of the disease. Those are the legal implications because this thing, of course, are implicated, of course, with legal aspects. Okay? So drugs with use, of course, with this one, nucleoside reverse transcriptase inhibitors. I don't want, of course, to explain that one, but this is the first one. Retrovird AZT, the golden drug. Okay? The first one. And right now, but sad to say, even a lot, of course, of people doesn't have any access to this medication. Okay? This could give the patient, this one, or the nucleoside, and there's a non-nucleoside reverse transcriptase inhibitors, Veramune, Sustiva, protease inhibitors are the term lines, okay? But the question will be is that the viral load, and again, how anybody who is HIV antigen positive, okay, will be labeled as HIV patients. Now the question will be, the one common problem here in these drugs, we have a lot of side effects. That is why compliance with the drugs is very, very hard. But definitely, if you have HIV, you need, of course, to take antiretroviral drug, or else it will progress to AIDS. Okay? So HIV, okay, antiretroviral, HIV is not. Why are you backing back? I'm doing that. HIV. Now, the difference between HIV and AIDS. First one is that, because again, the target of cell, of course, the target cell of your HIV is your CD4 count. We count, of course, your CD4. So viral load, you know the impact of this one. Effectiveness of antiretroviral drug therapy, as well as the current status, of course, of the patient in terms of how many viruses they got. The higher the viral load, the higher their capacity to infect other individuals, and again, the higher the damage of their CD4 lymphocytes. Now, how would you know that your CD4 lymphocytes is still healthy or you are immune healthy? Provided that the count of this will be between 500 to 1,500. Is that correct?
Yeah.
500 to 1,500. Some books of course will be 1,200. Okay, but again, 500 was the minimum. Between 500 to 200, you will see a manifestation, of course, of a lot of other conditions. Pneumocystis cerevisiae pneumonia will be there, and the likes. Okay? So, but again, the only thing is that if the CD4 lymphocytes will be lower than 200, okay? Even without the presence of opportunistic infections, this HIV now will be called patient with AIDS. What does it mean if you have a CD4 lymphocytes of below 200? It means only one thing. Your immune system is totally damaged. Could we elevate this one? Well, it could be, but the only thing is that we have to give antiretroviral drug so that again the virus will not replicate and again destroy more of your lymphocytes or CD4 lymphocytes. Okay? But the only thing is that if you see, of course, in between this area, 400 to 200, you see, of course, the opportunistic infections, of course, that will be manifesting. So again, one, a patient who has HIV, whose count is lower than 200, is labeled to have AIDS. Number two, HIV individuals, even without this count, with the presence of opportunistic infections, OIs, we call this patient has AIDS. Example, if the CD4 lymphocyte, of course, of this patient is 800, normal, okay, therefore we call this patient HIV still. But even if the value of the CD4 count is 500 to 1,500, normal, and there's already one present of OIs or opportunistic infection, this one will be your Pneumocystis carinii pneumonia, the patient will be labeled as having AIDS. So how do you define HIV? Individuals who have the presence of HIV antigen in their system. Clear? Meaning to say they have the virus. Who are the people who labeled with AIDS? These are, of course, the terminal stage of HIV, wherein they damage already the immune system. So meaning to say, if you have AIDS, meaning to say the HIV has already created damage to your CD4 lymphocytes because it's the primary target cell of the virus. Clear? So how do you progress? Definition, of course, of AIDS, anybody who has HIV positive that has a count of 200 or below. Clear? Or sometimes, even if the count is not below 200, if they have one of the 26 opportunistic infections, what are these? It will follow, of course, in your table. If they have one, Kaposi sarcoma, okay, cryptocardiosis, okay, then definitely we label them to have AIDS. The only problem sometimes is that even their CD4 lymphocyte is around 400, they have already one of this. Therefore, if they have 400 plus OI equals AIDS. Clear? That's the technical description of the HIV/AIDS. Okay? Okay. So count below 200 per cubic mm considered to have AIDS, or persons with HIV and certain OIs, opportunistic infection. How many of this? 26 of them, including wasting syndrome. Okay? Candidiasis, thrush, that you make yeast infection in your vagina that make it itchy. Okay, that's yeast. Okay, that's fungus. Cryptococcus, that cause, of course, causing the blood. Herpes simplex. Histoplasmosis. Mycobacterium avium complex, or intracellular, from the bird itself. Pneumocystis carinii pneumonia, now known as your Pneumocystis jirovecii pneumonia, PJP. Instead of, it might be the one that when you take your NCLEX, it is no longer PCP, but it should be PJP, the same name. The name right now is changed into Pneumocystis jirovecii pneumonia. Toxoplasmosis, Toxoplasma gondii. In constitutional disease, just like weight loss of greater than 5% of body weight in a month. Okay? Kaposi sarcoma. So the approach to treatment will be prevention of the opportunistic infection, early treatment of the infection. Therefore, one way to prevent HIV will be to do safer sex. Protect yourself. Okay? But sometimes do not tell me, of course, that I don't want, of course, I don't want to eat my sausage with casing. Okay, forget about it. The casing will gonna protect you, of course, from something. Okay? Or I want my banana peeled. Okay? So you have to learn how to eat your banana with wrapping, okay? Or else you're gonna be, your risk, of course, will be high. Okay? But again, if you have monogamy, as we have said, faithful monogamy, so again, we don't need, of course, to worry about it. Is that it? But if you have polygamy, Monday, Tuesday, Wednesday, Thursday, Friday, Saturday, Wednesday, work. I need, of course, to get the $35 for the remedial exam. I'm going back again to that, isn't it? Okay, so medication and prevention Condoms doesn't guarantee. Okay? Condoms doesn't guarantee. The only way, of course, to prevent HIV transmission is do not
Abstinence.
engage sex at all.
Abstinence.
Abstinence, that's correct.
Just sleep.
Okay?
Lock it up.
Or, you don't. So what is your favorite song? I have two hands. I have two hands, the left and the right. No, just go ahead, man. You just sing, of course, all by myself.
Sariling sikat.
Okay, that's one thing, isn't it? Never with cup needles. Okay, so this one, the nursing concerns, of course, for us is that especially one important especially for needle stick, you have to call your PPE post-exposure prophylaxis, which is very important, especially for healthcare workers. We know, of course, that the least, of course, we could get, of course, would be hepatitis, but if you have hepatitis, there will be a lot of massive consequences. Therefore, I urge, of course, that within 72 hours, we have to contact, of course, our carrier for your post-exposure prophylaxis. For each company that we are working, there is, of course, a part and a policy and procedure. How do we follow with needle stick? You need to be checked. Okay? Post-exposure prophylaxis. Okay? Any questions? If you don't have any questions, I'm gonna play a video. This is my friend from Johns Hopkins Hospital, and she will gonna enlighten us some more with HIV. Okay? Johns Hopkins. Ready?
You've probably heard a lot of confusing talk about the disease known as AIDS. So what exactly is it? AIDS is a disease that represents the final stages of infection with an incurable virus known as the human immunodeficiency virus, or HIV. To understand how AIDS works, it helps to have a grasp of HIV. Simply put, HIV attacks and destroys cells in the immune system, much as an invading army might destroy a high wall that protects.
By the way, I got this from YouTube. Okay, but this is very insightful. Sometimes if I have some time, I view YouTube, I research for the videos that could help me augment, of course, my explanation. This is a very good presentation, okay? The title of this one is HIV. I'm gonna go back later for that.
Texas City. With a weakened immune system, a person becomes less able to fight off infections. Before HIV can attack, it has to get in. HIV lives in bodily fluids like semen, vaginal secretions, blood, and breast milk. A person who carries HIV can pass it to another through any of these, usually via sexual intercourse, breastfeeding, or the sharing of drug paraphernalia. Rarely, a person will contract HIV through blood transfusions, and while it is highly unlikely for people to acquire HIV through saliva, it is possible to pass it through oral sex. Once the virus is transferred, it attaches to its new host body's CD4 cells, or T cells, which are integral parts of the immune system. Inside the T cell, HIV literally changes to become part of the body's DNA, or genetic code. At this point, the body will be forced to produce the virus. Because HIV lives in the immune system, every time a foreign invader triggers this system to work, HIV is activated too. This means that when good T cells fight, for example, the flu virus, new HIV particles are formed. During the first days and weeks after a person is infected with HIV, he or she may experience flu-like symptoms, such as a fever, fatigue, and enlarged lymph nodes. These symptoms generally disappear without treatment. But, as the body is forced to create new HIV cells, the immune system gets weaker, a progression that can take from several months to more than 10 years. Eventually, untreated HIV leads to acquired immune deficiency syndrome, or AIDS. The name is appropriate. Acquired means to obtain an infection. Immune deficiency refers to weakness in the immune system. And syndrome is a group of problems that comprise a disease. AIDS is generally diagnosed by a blood or saliva test that measures the CD4 cells in a person's body. If the count drops below 200, the immune system is seriously damaged and unable to fight infections properly. A diagnosis of AIDS also occurs if a person gets one of 26 opportunistic infections, which are conditions common in advanced HIV patients, but rarely found in people with intact immune systems. Most people who die of AIDS do so from one of these infections, but while there is no cure for the disease, the introduction of highly active antiretroviral therapy has caused the number of AIDS-related deaths to decrease significantly. Over 1 million Americans are infected with HIV. Because 300,000 people are still unaware of their HIV infection, getting tested and making sure you know your partner's status is essential.
Want to learn more? Check out other videos and sources on this site for more information. This year, in the United States, 42,000 people will become infected with the virus that causes AIDS.
AIDS is an incurable disease that is the end result of infection by the human immunodeficiency virus, or HIV.
What happened? Hold
An
on.
individual
Where are you? Okay, here. No. Okay, we're gonna do for Rita.
This year, in the United States, 42,000 people will become infected with the virus that causes AIDS.
AIDS is an incurable disease that is the end result of infection by the human immunodeficiency virus, or HIV. An individual who contracts HIV may become sick quickly or can live symptom-free for years. HIV and AIDS are not one and the same. Those with AIDS are infected with HIV, but people infected with HIV do not necessarily have AIDS. A person has AIDS when their T-cell count falls below a measurement scale of 200, as opposed to the 500 to 1500 in a healthy person. An extremely low CD4 count means that a person's immune system is no longer healthy enough to fight off intruding viruses and bacteria. Signs that HIV may be turning into AIDS include extreme fatigue, rapid weight loss, persistent diarrhea, a high fever, and swollen glands in the neck, armpits, or groin. Even if a person doesn't have a low CD4 count, they are still classified as having AIDS if they contract any one of 26 opportunistic conditions. These are a group of illnesses that don't generally occur in people with functioning immune systems, but do show up in AIDS patients. Two of these are cancers. One, Kaposi sarcoma, results from a tumor in the blood vessel walls and appears as disfiguring pink or purple lesions on the skin and mouth. The other cancer, non-Hodgkin's lymphoma, originates in the disease-fighting blood cells known as lymphocytes. This appears as swelling of the lymph nodes. Several opportunistic conditions that confirm an AIDS diagnosis stem from invading bacteria like tuberculosis and recurrent bacterial pneumonia. Pneumocystis carinii pneumonia is a potentially deadly inflammation of the lungs that is one of the most common infections occurring in people with HIV worldwide. Tuberculosis is the leading opportunistic infection in nations where access to medications is low. It occurs when bacteria infect the lungs and can manifest as coughing with bloody mucus. Sometimes an opportunistic infection can be fungal, like candidiasis. When candidiasis causes a white coating to form on the mouth, tongue, or vagina, this is called thrush. Although HIV itself is a virus, another virus can enter the body and cause an opportunistic infection. One example is cytomegalovirus, or CMV, a herpes virus that healthy adults fight easily. In people with HIV, however, the virus causes damages to the body, most notably the eyes. If untreated, CMV can lead to blindness. Other complications that lead to an AIDS diagnosis include wasting syndrome, whereby a person loses at least 10% of their body weight, and AIDS dementia complex, where nerve damage causes diminished mental functioning. These conditions and others mean that HIV has progressed to AIDS. While this is disheartening, many modern medications can keep AIDS infections from progressing indefinitely. If you have HIV, talk to your doctor about diseases that can occur following infection and the best ways to treat them.
Want to learn more? Check out other videos and sources on this.
Did you know that 25% of Americans who have the virus that causes AIDS don't know they're infected? For this reason, testing is essential.
Before a person becomes sick with the potentially deadly disease known as AIDS, he or she must first be infected with the human immunodeficiency virus, or HIV. This virus is spread through the sharing of blood, breast milk, semen, and vaginal secretions. While anyone can contract HIV, some people have a higher risk than others. These include people who have unprotected vaginal, anal, or oral sex with multiple partners, people who have injected drugs with shared equipment such as needles, people who have been diagnosed with another sexually transmitted disease, and anyone who has had sex with a partner who engaged in these acts. Men who have sex with men and people who have unprotected heterosexual contact make up 79%, or 4 out of 5 of new HIV cases, so these groups in particular should be tested regularly. When a person contracts HIV, his or her immune system starts to produce antibodies against the virus to ward off infection. Although these antibodies are not effective in fighting HIV, it is their presence in the blood that results in a positive HIV test. This test can be conducted at an STD clinic, a government-funded HIV testing site, a hospital, or a doctor's office. The screen can be done in a number of ways, but the most common is a conventional blood test. A similar HIV test involves an oral fluid sample which is swabbed from the inside of the mouth before being tested. A slightly less accurate method involves a urine sample. In all 3 of these tests, results should arrive within 2 weeks, and a positive test must be followed up by a confirmatory one. This guards against the risk of a false positive. For individuals who are in need of a very quick result, a rapid test is also available. In a rapid test, a blood or oral sample is collected and tested immediately in a lab. The results are available in as little as 10 minutes. No matter the type of test, the procedure can be very scary, and for this reason, many testing centers provide counseling. If you'd rather not get tested in public, you have another option, home testing. It's important to know that only one home testing kit is approved by the FDA, the Home Access HIV-1 test system. A home testing kit allows a person to prick his or her finger, place drops of blood on a special card, and mail the card into a lab. An HIV test can be scary, but a negative result would put your mind at ease. If your HIV test is positive, you have just taken an important first step on the road to treatment.
To learn more, check out other videos and articles here at sexhealthguru.com.